Good evening, everybody. We'll start the next session. The first talk is on art of managing postoperative surprise in cataract surgery. We all have experienced this, and we will hear from the expert, Dr. Chitra Ramurthy. Over to you, madam.
We want the previous audience, people in the previous session to sit and create the audience. No, go to the first line. It's okay. Oh, yeah, it's okay. It doesn't matter. You are hearing it. It's okay. Yes. A very good evening to the moderators on the dais and a few of you all in the audience. My due in the next few minutes is to talk on the art of managing post-op surprise in cataract surgery. Basically, these are a group of patients, premium patients, who have been promised visual independence, and the fact that they have a residual refractive error, they are going to be after you to enhance them, to correct them and get them relieved somehow, just that group of patients. So first and foremost, we need to understand what is the source of this residual refractive error. It's quite likely, more likely to be an inaccurate biometry, wherein we have missed out those red flags, which is so critical. We need to look at the standard deviation. We need to look at the signal to noise ratio. We need to look whether there was a disparity between the two eyes, whether the K value was more than 0.3, whether the IOL power was more than 1 diopter. Everything needs to be looked out. We need to rule out whether it was a wrong IOL selection. Like the patient thought he's going in for a trifocal and has not understood that we were promising him an EDOF or an enhanced focal. So that's the wrong choice which you have done. It could be a transcription error or it could be a handwriting misinterpretation. So the best way to deal with all of this is to do your best before the surgery. So we need to use the right formula, and we now know that we have the 4th generation formula and beyond. And it becomes absolutely important for us not to hold on to what is old and gone and use the best, which is going to take care of all the extremes of situations. Ensure that the measurements are accurate, and if there is a disparity between two readings, repeat it. Sometimes it could be a dry surface because of which there's an error in our biometry measurements. We need to validate it. We need to ensure that the readings are consistent. The good news is that we know that the Hale RBF, the Barrett Universal 2, and the Emmetropia verifying optical formulas are all 92% of the situation within plus minus 0.5 diopter of target, and that is good news for all of us. We also know that in the segment of multifocal, the patients are not tolerant with the least amount of astigmatism, and we need to ensure that they get a toric multifocal. The problem is not there in 70% of the patients. In only 30% of the patients, you realize that you look at the keratometry, the standard deviation is more than 0.2. Then could it be dry eye? Then if it is dry eye, treat it and then take your measurements. If it is not dry eye, it could be a refractive surgery eye, it could be an early keratoconus, it could be a PMD. Then you do a topography. You definitely need to do a tomography in these eyes. And if there is a toricity there, you need to use the toric calculator and need to use the best of the formulae and get the best of results in that 30% of the eyes. It goes without saying that it has to be a perfect phacoemulsification, a proper wound architecture, the proper overlap of rexes. It has to be a proper viscoelastic removal, and most importantly, before we step towards premium IOLs, we should ensure that our post-op outcomes are absolutely bang on optimal. So you also need to determine what went wrong. So first and foremost, you do a refraction, wait for a stable refraction, the cornea to clear up. It could be a post-RK patient when there could be some transient hyperopia. We need to look at the IOL, whether it's subluxated, there's a PCR. We need to repeat our biometry. Was there something wrong in the initial thing? We need to know that what was the biometry? Was it the IOL implanted, or was it a wrong IOL labeling when we need to remove the lens? Now, this was a patient who had a +8 diopter of residual refractive error, and which so clearly that something was bizarre in this patient and it has to be addressed. But we need to follow the whole protocol, and in this particular case, we realized after checking all our records that it was a wrong IOL labeling. So then, in general, what are the considerations? I said stable refraction, it is mandatory. We need to look at the age of the patient. Do we need to repeat all the physical evaluation? Is he fit for a re-surgery? Or what was the challenge in his primary case? Was it that his visual needs were not met, that he felt that his reading ability or the intermediate vision was not as good as promised? Could you have compensated by doing a binocular procedure? Is it that the dryness of eyes was a problem? Is it that zonules were weak, so the lens was decentered? And you also need to look whether there was a posterior capsular opening was there. Then we may not be able to very safely do an IOL exchange. So all of this needs to be done. We also need to plan when we are going to do an enhancement, whether you are going to allow for a neuroadaptation. But then, if it is a wrong IOL par as that situation, it needs to be removed. But if it is a cylinder and it's a toric IOL, you could even rotate it after max waiting for a week. Now, this was a patient, a 65-year-old with a small residual refractive error, as you can see here. And this needed to be addressed because he was coming back again and again. So we need to do a topography, need to do a refraction, need to see whether the cornea is thick enough to do a surface ablation or a PRK or a microkeratomy LASIK. But we need to be very, very sure, and majority of these patients, if you are taking good care of the dry eye by keeping them on artificial tears for more than 3-4 months, looking at the mebomitis, they are fine. Now, if it is a post-toric, we need to look at the refraction carefully, whether the spherical equivalent is 0. If the spherical equivalent is 0, you know this is the ideal case for a toric IOL rotation, and that would sort him out. In that situation, all you need to do is just to open up the incision, no viscoelastic, keep the infusion on, just reposition the IOL by just using a dialer. And in case it's a high myope, or you think that it keeps sliding back, you could even consider using a CTR in these patients. Going back to that plus 8 diopter, the only way for him was to have the IOL removed. So if it is hydrophilic acrylic, we don't even have to cut it. You could just hold it at the optic-aptic junction and pull it out. But if it is a hydrophobic acrylic, you need to hold it at the optic-aptic junction, and you need to cut the optic of the lens. You could do it just halfway and use that point as a fulcrum and pull it out, and then go ahead and replace with another IOL. Now, this was a patient wherein it was a plus 3 diopter of a residual, and the patient was advised a hydrophilic sulcoflex lens, and you know it has a large optic, it has undulating haptics, it has a posterior concavity which creates space between the primary IOL and this, and the material of the lenses need to be different, and that is the solution, and you can see the post-op vault was quite good. The second eye actually gives us a chance. I'm concluding. Basically, if the first eye was a VBT and the patient was wanting more near vision, you could do a panoptics in the other eye. If the primary IOL had a geometrics, you could do a geometric plus in the other eye. So there are different ways, and in this particular patient, his intermediate vision was clear, but his near vision was not good enough. So this was an old situation wherein a Technis +4 was given to this patient who was an avid reader and which was overlooked. This is a case again of a Symphony IOL. The patient had a +0.5 for near, and all that you need to do is a micro monovision. But let's remember that between the two eyes, the disparity should not be more than 0.75, because that would affect the stereopsis of these eyes. So there are different ways you could deal with the second eye, but if a patient is 6/6 with a residual error but is happy, you could just leave him alone. So essentially, the content is that there are many ways which we could skin the cat, and residual refractive errors, if that is the cause for a patient dissatisfaction, it could be dealt with. Maybe we could wait for a breakthrough technology not so far away in future when there could be a post-op IOL par adjustment, and that is what the patient would need. Thank you very much.
Thank you, Dr. Chitra, for highlighting the management of post-op surprises. Next, we have a change of presenter. Next, Dr. Ramurthy will be presenting on unhappy patients, unreasonable, manageable.
Dr. Chitra, just one question, madam. When will you plan the rotation or repositioning of the IOL? Yeah, toric.
If the spherical equivalent has to be 0 when you do the refraction, that is +2 with -3.5 or something like that, you know that the spherical equivalent is 0. Those are the cases wherein you do a toric IOL adjustment, and then you need to go back either on eye trace or whichever there are different ways of checking that the direct RF formula. You will know what is the axis of placement, and then you take the patient back to the theater. You could do it right away if it's a very high cylinder, but something small, they say that the maximum location occurs with the first hour, but you could wait even up to the week and see whether the IOLs will
Okay.
thick and then.
Okay, thank you.
Thank you. I think just to follow up on Chitra's talk, how I deal with my unhappy post-operative patients. I think the most important factor is to the pre-operative counseling, where you always tend to under-promise and over-deliver. What we are not talking about is bombastic words like throwaway glasses, but what we tell to the patients is less dependence on glasses if you're considering a multifocal intraocular lenses. Obviously, you would explain about dysphotopsia, tell them that bilateral surgery would enhance the quality of vision that these patients enjoy. In case, as was seen earlier, in case there is a suboptimal outcome, a touch-up procedure might be needed, which we obviously do free of cost. Then neural adaptation, which will be my last slide, is also the challenge as well as the friend for us in these situations. What exactly are the causes of dissatisfaction of these patients? I often say that it's 5 C's. Often we allude it to the sixth C, that's a crazy patient. But that's because of inadequate understanding of the problems that these patients have. Once you look at it deeply, most often you are able to identify the cause, at least mitigate it to some extent, even if not do away with it completely. I'm not going to be dealing with residual refractive errors because the earlier speaker just spoke to us about it. But one of the determinants which causes a significant deterioration of vision is the posterior capsular opacification. And ideally, you wait for a period of 3 to 6 months and create an opening like this to open up the capsule. And before doing this, it's always a good idea to ensure that it's not the lens per se which is the cause for dissatisfaction. And if in case a IOL exchange might be contemplated, it's better not to open up the capsule. Obviously, it's a no-brainer as far as a capsular thickening like this is concerned. But what about a situation like this? Especially if it's a multifocal intraocular lens, these are two eyes of the same patient that I had done. Here there's an excellent rexis overlap. Here there's a sort of a rexis runoff, because of which about 6 months down the line, you can see the patient was still reading 6.6, but he was not quite happy with the quality of vision, constantly comparing with the other eye. Even a diaphanous PCO like this causes a deterioration, and your threshold for doing a YAC capsulotomy, these patients have to be quite low. And once you have checked the retina, made sure it's fine, and go ahead and do this, you would often find that a simple YAC capsulotomy does enhance the quality of vision that these patients have. One factor which we do not often talk about, we do not concentrate on, is the centration of the intraocular lens. As you can see, again, bilateral implantation of the patient, and you can see because of the diffractive rings that are there here, you can notice the excellent centration of this lens. On the other hand, this lens is decentered. That's again because of the capsular rexis overlap being inappropriate. And in these situations, because the induced coma, especially with the multifocal diffractive lens, if you have a situation like this, the quality of vision would be quite compromised. And here, of course, if the capsular rexis margin is quite intact and it's possible to reposition the lens by doing a surgical recentration, that would be the procedure of choice. What has also been suggested is laser spots being placed in the periphery of the eye, in the close to the pupillary area. This causes shrinkage of the iris and draws the pupil in this direction. I've just done it in 2 eyes, and there's significant amount of pain, irregular pupil at the end of the surgery, and quite a bit of pigment dispersal. So obviously it's not a great way to do. Prevention is the best way, and it's always important, especially if you're dealing with a premium IOL, to ensure that the intraocular lens is well centered straight away. Severe negative dysphotopsia, that's nothing else than the patient complaining of a shadow on the temporal aspect. And this is, there are several ways of dealing with it. One is a YAC capsulotomy to the nasal ridge, or you can place a neodymium ND ring on top of this lens. In this case, which is operated by a colleague of mine, as you can see, it's an excellent toric intraocular lens implantation. The lawyer by profession has a 6.6 visual acuity, persistently complained of dysphotopsia, because of which 6 months down the line, after counseling the patient, we went ahead and placed a a sulcoflex lens. This can come even in a zero diopter lens, and as you can see, you need about a 2.8 to a 3 millimeter incision in this, and this is the lens which goes in. It's a 6.5 millimeter. The most important aspect that it's a round edge optic, and it's a 14 millimeter overall diameter, because of which, and so as you can see, it's a undulating haptics, because of which it stabilizes nicely in the sulcus. And since this overrides the square edge optic of the primary lens, and the material itself is hydrophilic acrylic, the cause of the negative dysphotopsia is supposed to be from the capsulorhexis margin nasally, which overrides the square edge optic of the lens. And once this is hidden by the optics of this, by the rounded edge optics of this secondary lens, that seems to go away almost immediately. The ND ring also serves a similar purpose. One other way to do it would be to do a YAG laser. Obviously, in this case, I did not want to do that because patient had an excellent visual acuity outcome and did not want to compromise that by disturbing the lens in the back, and so chose to put in a second lens. You already saw it in a different scenario. This is the primary lens, this is a secondary lens, and this is a separation. This is because of the particular angulation of this lens, and this is the KSOC2023 pictures which is showing the two lenses. One of the commonest problems that we have is excellent results. Optometrist is happy, surgeon is happy, the lens looks great on the patient's eye on the slit lamp, but the lady is most unhappy, and she'll go around. Mind you, it's not the industrialist who will spoil your reputation. This lady who will go around telling each and everyone who is willing to listen to her in a colony, in a family, telling that before the surgery was much better. And quite often, in spite of an excellent visual outcome, is that dry eyes which is the problem. And often the patients obviously do not complain of dryness of the eyes always. Whenever they have fluctuating vision, photophobia, fatigue towards the evening, increased mucus material, and when you stain, you see a picture like this, you should suspect this. Almost 70% of the patients who present to us for cataract surgery are predisposed to dryness. And the most important factor you must remember that is when you're dealing with a situation of dry eyes, post-operative medication, less is more. The less you prescribe medicines, the lesser are the chances that the patient will present with the post-operative dryness. Pardon me for the trade names being mentioned because it's a screenshot of the actual prescription. As you can see, what we give is just four times a day, 2 weeks of moxifloxacin dexamethasone combination. After that, completely withdraw that. Then two times a day, NSI drops for 6 weeks, and plenty of non-preserved carboxymethyl cellulose eye drops. You could use other lubricants also. And once you do this, at least the run-of-the-mill cases seem to do well. At least you would not be inducing dryness in these patients. Obviously, it's also, I think most of us have made it mandatory to have a look at the retina, not just by indirect ophthalmoscopy or direct ophthalmoscopy at 90D, but also doing doing an OCT, and you can see a epiretinal membrane like this. Very often a casual retinal examination by anterior segment surgeon could miss all these problems, and whenever you do a cataract surgery with or without a premium IOL, obviously this would lead to a suboptimal outcome. And forewarning these patients about this, and then preparing them for this and addressing it properly would be a good idea to deal with this. This is something that I have whenever a patient of multifocal intraocular lens complains of dysphotopsia. Very often it's an observation and not a complaint. I have these -2 diopter lenses, ask them to wear this and try to read. Immediately they understand there is a much to be gained. I say I can replace it with a monofocal intraocular lens, but this is what you will get if I replace it. And immediately they understand the value that has been brought in, and quite often they delay or just postpone. So far, in more than 15 years of putting in multifocals, I have just removed a couple of lenses for the reasons of dysphotopsia. This was already mentioned by Chitra. This is again emphasizes the importance of doing a correcting cylinder whenever you faced with toric multifocal implant. Initially, we had done a symphony toric. Patient was quite happy, but then, as you can see, it's a 6 by. He required a near correction for as far as near vision is concerned. So essentially, instead of a EDOF toric, the patient received a trifocal toric in the second eye. So it bilaterally implanted, the patient ended up with optimal results. And neuroadaptation is also the problem as well as the solution. whenever the patient has a problem and you find everything is normal, you counsel the patients to wait it out, and most often you find that in 6 months down the line, you end up with a happy patient. And the final slide, but perhaps the most important slide, is that whenever a patient comes to you with a postoperative problem, please do not get aggressive. Agree with the patient. Tell them that you know this problem could be there. This is going to settle down. Prescribe them whatever medication. Counsel them. Once they understand that you are with them and your reassurance is there and you can promise a solution, most often half the problem disappears. Thank you so much for your kind attention.
Thank you, sir. Thank you, sir. That was a wonderful presentation. It's very difficult to sum it up all in 7 or 8 minutes. And what you said is true. Patient is always right. You have to take it. Just one question regarding the NSAIDs, especially in severe dry eye, it produces even corneal melt. So do you find any difference between these various molecules like nepafenac or bromfenac or even high dose nepafenac? Which is the best?
We have been using this Nefenac most often, and I don't really find any big difference between any of these molecules. And one thing is that whenever there's severe dry eyes, I was essentially talking about run-of-the-mill cataract cases who have a problem and we don't want to induce dry eyes. But if the patient presents with severe dry eyes, maybe I would avoid using a NSAID drops in those cases.
One small tip regarding centration of multifocal lenses. After you finish implanting the lens, just ask the patient to look at the light and you just coincide it with the Purkinje image. So if you find the center is coinciding with the Purkinje image, it's as good as the center, the central ring. I'm telling about the central ring.
I completely agree with you. I also do that. But I think that's more for our satisfaction rather than any true benefit, because for the simple reason, all the lenses that we implant are about 13.5 millimeter overall diameter. The capsular bag is just about 10.5 millimeters. So the lens essentially sits depending upon the dimensions of the capsular bag, and even whatever position you leave it finally is going to settle down in a position where according to the dimensions and the direction of orientation of the lens. So, but if it's a well done surgery with a regular 360-degree overlap, you find that especially with the 1.4, 1.6 millimeter central ring, it centers quite well.
Thank you, sir.
Thank you.
One more question, sir. You put that piggyback lens for that. That's a single piece lens. Is it advisable to put it in the sulcus?
There are certain variations in the sense it's a hydrophilic acrylic lens, not a hydrophobic. The square edge is not a square edge but rounded edge. So the chaffing of the back of the iris is not there, and the entire even the haptics are quite soft and undulating. And yes, it's not a good idea to put anything in the sulcus, but then this is much better than having a hydrophobic acrylic with a square edge.
Thank you, sir.
Thank you, sir. Next is the dilemma. We all have sometimes when there is a VIP patients, the Murphy's laws apply. If something is about to go wrong, if something is bound to go wrong, it will go wrong in a VIP patient. So we will see how Dr. Ragini handles those issues.
Thank you, sir. Good afternoon, good evening, everybody. Respected Dr. Rajiv Sukumaran, sir, Dr. Sashi Kumar, sir, Dr. Joseph, sir, and all the friends here. So, like sir said, that if there is a VIP patient, what do you do and how do you deal with it? Very simple points that every patient is important and the doctor-patient relationship is the most important. Like you saw in one of the slides of Dr. Ramamurthy sir, that many a times what the patient needs is a lot of reassurance. They have problems which you may or may not be able to solve, like the glare and all that, but reassuring the patient is very, very important. So what is important is the trust. You cannot betray the trust that the patient has in you and always go by the truth. Now, why the truth is because we are a lot of educated doctors and not everybody will be the same. So if you do not tell the truth, there will always be somebody who will tell them what is happening, even though you don't expect your friends to do so. So, so it so happens sometimes that the patient is very scared and so can be the doctor, very, very scared. Now, who are the VIP patients? if you have a public figure who's a politician or a bureaucrat, in our country we place them very highly, and they themselves place themselves very, very highly. So the politicians and bureaucrats, the journalists, every time, when I was in a government hospital, if there was a line, the journalist would come and say that I'm a journalist, I'll do this, I'll put that. So they try to threaten you, and those are the people. And we used to have a huge OPD and a OT. So the journalist would always come without the appointment, but the judges and the ministers would come with an appointment. And the politician, though you feel that they would be bad, they were very humble, because they cater to patients, to people, to get votes. So they are more humble than you expect them to be. If it is a close relative, it is a VIP patient, because you will always think about them, your next door neighbor, because you have to see them every day. Friends, relatives, and a one-eyed patient. One must always remember that in our setup in our medical college, we always said that the one-eyed patient was the real VVIP patient, because you have to take extra precautions to see that whatever happens to the patient, that eye is not lost. Means to get the patient operated by the senior most surgeons, to give the best to the patient. Like, because it was a general hospital, if we were not able to do phaco for that patient, we would pay for the lens ourselves or with donation, so that the patient would have a small wound. So you have to keep in mind that the VVIP patient is not necessarily a VIP according to the rules of the society. You have to think who the actual VIP is. So what are the matters of concern over here? What are the do's and don'ts? So you have to examine and evaluate, like in any other patient, which is very important for all the patients, because you are a doctor and every patient is a VIP. But for example, if it is a politician who has security, who's the judge who has security, the timings of the judge are important, then you have to make their entry and exit quick. For example, we had Asha Bhosle ji as our patient, and she would get mobbed. She's quite old, so you have to be careful as to how her entry is, how her exit is, and how fast it is, so as she doesn't get mobbed. Then we had a governor as our patient, and who got operated by sir. In fact, he was the governor of Kerala that time, Gavai sir. And I remember the SDO saying that you cannot patch the eye. Many years back, now topical we don't patch, but he said he has to go out into the car and you cannot patch his eye post-operative. So many things have to be taken care of. If you think that there is a dilemma, it is always good to take a second opinion, so as to not make mistakes, and in the next few slides will tell you why. Lahane sir was just telling yesterday that you enter the OT when the patient is draped for yourself, because then you don't see the patient, you don't think that, oh God, you're operating so and so person, like say if it was somebody. And so when the patient is draped and when you see the eye, naturally all of us who are doing surgeries get transformed, and you start thinking only about the eye. So if the patient is draped, you are seeing only the eye. I think a little bit of help comes there. And Arjun had to see only the eye, and that is why chair time needed is more in many VIP patients. Like, they need more time, they need more answers, they demand more time actually. So you have to give in to the demands if you are accepting such a patient. And the VIP syndrome can affect your diagnosis and decision making. There is always something or the other goes wrong in the VIPs, and that is how the VIP syndrome came into being. Touch only what you think you can lift. So one has to be very, very practical. The so many years that I was in JJ hospital with Lane sir, and sir used to do pediatric cases. I never ended up doing cases, and then after a certain time, I thought that there's so much ophthalmology to be done. This little child who is 19 days old needs the best surgeon, and so I won't touch this child. And then again, and I won't touch this child. And I never did pediatric cases. So there is so much to satisfy you as a surgeon. So you have to know your limitations. Whenever I had a black cataract, 1 month Lahane sir was laid down with a back problem. I did all the black cataracts, I did SICS. I did not do phaco because I knew my limitations. So you have to know whether you can touch the VIP, whether you can do the VIP. One president, ma'am of India, was operated and she had a chronic red eye. Because wherever she was operated, maybe they got scared and all. So that is worse than not doing the patient. So what are the pros? it can bring you a lot of fame and reputation. So you are doing a VIP patient, and everybody is interested that where the VIP got operated, so that if the VIP considers that that doctor is very good, you will have a flock of patients. Sharad Pawar sir's brother-in-law, who was on the opposite party and who was the main person who fought the Enron controversy, Mr. N.D. Patil, he was first of Lahane sir's patients. And that is how the stream of politicians started coming to him in the last 30 years to judge, to almost all the ministers and all that. So it can bring you a lot of fame and reputation. But if anything goes wrong, like how I talked about the Honorable President, so madam who was operated by somebody else, and the second day after Lahane sir got his Padma Shri, he was called to see her eye. I will finish in 58 seconds. So it does increase the number of patients, it adds publicity, and every time a politician came, sir would extract money from him, from his MLA funds to build the government department. But it can go wrong, and you have to be very, very careful. So one has to be very confident. Don't be shy to take a second opinion. VIP patients are extremely important. It builds up your confidence as a surgeon. Once you are very confident, you can go ahead. I hear so many people putting on Facebook that I operated my own mother, my own father, and it's very good. Go ahead and do it, but know how much you can do. Don't forget that at the end of the day, the VIP is also a human with two eyes, and you are his doctor and you are superior to him. So please keep that in mind. And they came to you because they considered you as the best person. So thank you very much for giving me the opportunity to be here and be with everybody. Thank you so much.
Thank you, Dr. Agni, for that excellent talk and letting us know who the real VIP is. Next, we have a post-operative glass prescription and selection. Happiness for the surgeon and patient. Dr. Shivan was supposed to be here, but he's been represented by Dr. Privila. Go ahead.
Good evening, all. Today, I'm making this presentation on behalf of Dr. Shivan, our medical director. The topic is post-operative glass prescription and selection, happiness for the surgeon and patient. Even though this topic has some business aspect, I have no financial interest. This topic is being discussed under these headings. All through these years, we have seen improvements in cataract surgery outcomes. This has in turn increased patient expectation regarding postoperative visual acuity. But then, refractive errors after cataract surgery are relatively common, and that impacts patient satisfaction. These are the indication for spectacles after cataract surgery. Research states that on an average, more than 50% of patients wear spectacle after cataract surgery. And we have noticed all these changing trends, that more than 50% of population change their glasses in 1 to 3 year period, and this in turn increases the patient turnover. Spectacle-free cataract surgeries are actually very less. Few patients with high-power glasses, they wait for cataract surgery to avoid their glasses forever. When the patient hates using glasses, all these patients may insist for a spectacle-free cataract surgery. But are they all really happy? Can surgeon make them really spectacle-free after IOL surgeries? This requires best patient selection, best counseling. We have to understand the patient's expectation and explain the limitations. We have to tell the patient that they can't expect 100% distant and near vision. For that, accurate biometry is a must, and the patient should be free from retinal and corneal comorbidities. Coming to the disadvantages of multifocal lenses. They are very expensive, and implanting a multifocal IOL can lead on to reduced light intensity, reduce contrast sensitivity, increase in glare and halos. Even the new generation multifocal IOLs, they are not free from devoid of glare and halos. So, it is not very suitable for patients with heavy dependence on night vision, intermediate vision, or specific job requirements like commercial pilots and drivers. Next slide is actually explains an important aspect of this presentation. So, I'll be explaining it by showing you two different scenarios which usually happens in our hospital. Here you see a happy doctor and a happy patient. He underwent multifocal IOL implantation from our hospital. Then he goes back and started experiencing glare and halos. He comes back, questions the doctor, raises his concern, then this goes on and on. Then the patient gets irritated, the doctor also gets irritated. Then the patient is not getting convinced, so he goes for doctor shopping, and then we never know where he lands up. Maybe he comes back to you, or else he visits some other centers. But in the end, maybe you are getting a unhappy or not satisfied patient. See this. This patient actually underwent multifocal monofocal IOL implantation from our hospital. Then we have an in-house optical store. He went there and got himself an advanced progressive lens. Then he comes for IOL. Then he comes for post-op follow-up visit and visits opticals maybe every 3 or 5 years. And this provides a continuous source of income or steady source of income for the hospital. So here you can see the doctor is also happy and the patient is also happy. I assert I have nothing against multifocal IOLs, but here the clear winner is monofocal IOL implantation and giving glass correction later. Then coming to the spectacle selection after cataract surgeries. Selection as per the need of patient is very important. Plastic lenses are more popular these days because they are thin and lightweight. These are the three basic type of lenses which we give to the patients. I'm not going into details. So here you can see the progressive lens and the advanced progressive lens with very minimal peripheral distortion, and that provides wider distance, intermediate and near fields. These are the different tinted and protective coatings that you give. The anti-reflective coating eliminates annoying reflections from the anterior and posterior surface of the lens. It provides better vision for reading, computer use and driving. Blue light reduction coating is very popular these days because exposure to blue light without proper eye protection can cause serious long-term eye damage. It is mostly beneficial for people working on computers. Tints actually come in and out of style all the time. In addition to enhancing your looks, it serves various purposes. It protects against UV radiation, reduce contrast and improve glare. Photochromatic lenses immediately become dark shaded when exposed to sunlight. Anti-fog coating helps in eliminating the fogging effect. Scratch resistant coating can play a significant role in preventing scratches from damaging your lens. Thus, they help the lens to withstand the wear and tear of everyday use. Polarized coating reduce glare and provide UV protection. Here you can see that the light rays getting reflected from the surface is being filtered by the polarized coating. UV coating is used for protective purposes, mostly used in pseudophakic patients. The normal coating transmits 5%, whereas the best quality UV coating transmits only 2% of UV rays. Gradient lenses help to protect your eyes from overhead sunlight tinted from top to bottom. They are especially beneficial when driving to see the road and your dashboard better. So actually, you should be able to assess what is the need of the patient depending upon the affordability of the patient. For that, you should have an efficient operational team. The optical in charge must have a thorough knowledge about all types of glasses and frames. Up-to-date knowledge about the latest trends is essential, and a senior optometrist trained in optical is ideal. Take-home messages: assess, categorize, understand the need of the patient, educate the patient about high-end frames and glasses, focus on the need of the patient's accuracy after service. I'm sorry. Here again, you can see two sets of patients. The first patient is wearing glasses and he looks happy. The doctor also looks happy. In the second set, you can see the patient is happy and she says, I see so much better now after cataract surgery. But the doctor doesn't seem to be happy. Maybe she underwent multifocal IOL implantation and the doctor is being scared and he's thinking about all the other complications that may come later. Thank you.
Thank you, Dr. Pravila, for covering this vast topic in 7-8 minutes. The essence is that you promise less and deliver more, then the patient will be happy. Next is I would call upon the glaucoma specialist from Aravind Eye Hospital, Dr. George Puthuran, to deal with happiness post-cataract surgery in a patient with glaucoma. It's a very, very difficult and we all would have experienced this. to convince a glaucoma patient to undergo any surgery, because the chance of burnout will be there. So Dr. Puthuran will enlighten us about how he tackles these patients.
Thank you very much. So cataract coexisting with glaucoma, obviously your goals are visual improvement, and patient also needs to be comfortable and symptom free. And I keep saying this, it is as much to do with setting the patient's expectation from the surgery as it is with the surgeon's knowledge and skill. And it's cutthroat professionalism here, has more to play than empathy and compassion. See, these are all some of my personal opinions. Always when we prepare a presentation, there is a mother article or there is a textbook chapter. Unfortunately here I had to do a lot of my experiences in this presentation, and I am proud to say it's almost 25 years since I have been taking care of such patients. And unique challenges of coexisting cataract and glaucoma. Patients are on glaucoma medications. Any clear-cut primary open-angle glaucoma or ocular hypertension with a cataract, you will feel it is absolutely normal, but you have to be very, very careful. These are diseased eyes. These have a ocular comorbidity other than cataract, and these are prone for choroidal effusions. Choriocapillaries can leak. It can even sometimes lead up with a suprachoroidal hemorrhage. Pseudo-exfoliation, angle closure disease, secondary open and closed angles, post-trabeculectomy, post-GDD, and the most difficult situation of nanophthalmos. I keep telling my fellows in the theater, difference between an in-the-bag IOL and an IOL in the sulcus is almost like, the difference is like heaven and hell. Every eye, I keep telling them, has to be the Prime Minister Narendra Modi's eye or your mother's eye. One immediate question that comes up is effect of prostaglandin analog use on the development of cystoid macular edema after cataract surgery. Everybody keeps asking this. Do you stop prostaglandins before cataract surgery? Do you continue prostaglandins after cataract surgery? I looked at literature. This is only 2 randomized prospective trials are there. This was in the British Journal of Ophthalmology. The group stopped prostaglandin in one arm of 30 patients, continued prostaglandin in the other arm of 30 patients. All the 60 patients were on prostaglandins preoperatively, and continuation, and these are eyes with normal macular morphology. These are not diseased eyes. Continuation of prostaglandin therapy following uneventful cataract surgery in eyes with normal macular morphology did not increase the risk of CME. And continuation of PGA, the secondary outcome measure was intraocular pressure control at the end of 1 month. Continuation of the prostaglandin analog led to a much better IOP control after a final follow-up. The second randomized control trial I found was in the JCRS. Again, latanoprost was continued in one arm. Latanoprost was discontinued in the other arm. They looked at 1 and 3 months. They looked at OCT macular thickness at the end of 3 months. Again, there was no significant increase in central macular thickness 3 months post-operatively with the use of latanoprost. Continuation of latanoprost after uneventful cataract surgery is safe. This is a meta-analysis again in the JCRS. They looked at multiple published literature. They analyzed using the stringent reporting of observational epidemiological studies. They analyzed with the strobe statement methodology. Again, no evidence supports stopping PGA use prior to or post-surgery to reduce CME. Again, caution should be exercised in complex susceptible patients, and these are the risk factors. In our practice, any patient who has a posterior capsular rupture or vitreous loss, any patient who is an uveitic patient, other eye had an uneventful cataract surgery but developed CME. These are some of the instances. Diabetes mellitus, even with the CSME, you look at the potential benefit and then continue the latanoprost. My only advice would be, I have no financial interest here, prefer a latanoprost over a travoprost or a bimetoprost. The periorbitopathy with latanoprost is much less, and you see there is a lot of loss of periorbital fat, deepening of lid sulcus. It becomes very difficult to do even a cataract surgery in some eyes on long-term bimetoprost. And all what we have seen over the past 15 years came up in a publication from the Asia Pacific Glaucoma Society guidelines last year. And they spoke exactly the same, that latanoprost is much more ocular friendly than travoprost or bimetoprost. a few tips to my my junior colleagues here taking care of these high difficult eyes, especially these angle closure eyes, post-trabeculectomy eyes. Prefer to have a small volume, even a 1.5 ml of silocaine block, if it is given correctly in the subtenon space without any ballooning of the conjunctiva. It goes into the subtenon space, 1.5 ml, wait for some time. It's very comfortable to do a phaco in these patients. Again, I forgot to mention that initial decompression of the eye, initial decompression is take as much ever time as you want to do your first entry into the anterior chamber, both the paracentesis, because it is extremely important to have fine control of the anterior chamber. A sudden collapse of the anterior chamber can give you, your choriocapillaries can leak and it can be disastrous. Again, while inserting, always have the eye not too full with viscoelastic. When you put in your iris retractors, sometimes if it is very full, the iris is plastered to the anterior lens cap. So it's sometimes difficult to pick up the. Again, do not touch the pre-existing filtering bleb. It's extremely important. Even very good pre-existing filtering blebs still fail post-cataract surgery. Multiple publications, cataract surgery after trabeculectomy, you don't touch anything, beautifully controlled intraocular pressures with good avascular blebs suddenly become like this. Believe me, this was an avascular bleb. After cataract surgery, finally it went in for a tube, to the extent that sometimes when we have very avascular cystic blebs at the limbus, rather than doing a bleb revision, we sometimes do a cataract surgery and see whether the transient bleb leaks seal off. Tube shunts are more likely to have preserved function with subsequent cataract extraction than trabeculectomy with MMC. We also have our own results published on this. Extremely satisfying to have a cataract publication in a pre-existing Orolab aqueous drainage implant, where we showed that there was absolutely no significant rise in intraocular pressure or increased risk of RD failure after 2 years of follow-up. In doing an eye with a pre-existing GDD, usually it is, just don't think that there is a GDD there. Just continue your normal cataract surgery. Suppose you feel there is some kind of a fluctuation, you can use an iris retractor to tamponade the lumen of the tube before proceeding with the informed consent process. Is vital. Extends well and truly beyond what is documented and signed by the doctor, patient, or the attendant in a piece of paper. Some decisions have to be taken in consultation. See, this is an iridocorneal endothelial syndrome. Had a PSCC, nice PSCC in the visual axis. There is a high risk of corneal decompensation in these eyes, and naturally it ended up. But thing is, you need to give the option to the patient. You can give them the option of waiting for some time, or sometimes this happens. Again, another patient where an example where a decision has to be taken in consultation. This is post VR surgery, had an ACP doing well, but a nice posterior polar cataract has developed. Again, vision remains stable. You can always wait. That was what we would have advised. Just 1 minute I'll take. Happiness of the surgeon, I have also realized, is extremely important. At the end of the day, you need to have peace of mind. You need to be emotionally detached. Nowadays, the patient will say, my only daughter is getting married. I just want to say, you try to detach yourself, but try to do the best possible. I have also realized that not all battles can be won with intraocular surgery. We can only control the controllables. Medical science still has limits and clear-cut boundaries, and visual rehabilitation is also important. A process of losing vision in glaucoma is a very gradual process, but intraocular surgery can suddenly make the patient who walks into your chamber blind. This was a patient who had chronic hypotony reversed with supramid stenting. After cataract surgery, has 1/60 vision. The mother and the patient is coming and standing like this in front of me. Before cataract surgery, the patient's mother told me, see, this is my son. I have to lead him by hand and bring him to you. And if you hear that in Tamil or Malayalam, it will be much more striking. English doesn't actually convey the message. And this is my last slide. I still love what I do, even though it is not much less to do with worrying about very simple residual astigmatism and minor discomforts following cataract surgery. Ironically, the day before I was leaving from Madurai, my colleague comes to me and gives me a biryani packet. My colleague, I asked her, why you have given it to me? She said, one of my patients brought it to me today. it's an anophthalmic eye. I don't take non-vegetarian on Thursdays and Saturdays. And I asked her, how was the vision? She said the vision pre-operatively was perception of light. After surgery, it's hand movements. But the patient says, "Moonji ella nalla theriyudu, madam." So I leave it at that. Thank you very much. And it's always a privilege to be in KSOS.
Thank you, Dr. George, for that excellent presentation. I'm sorry we didn't have many people to hear you. Yeah.
Very emotional talk.
It's very difficult to handle cataract in glaucoma because see any moment you can expect a wipeout, but then you will have to do a cataract surgery in that way. It's very difficult to tackle such patients, and you have done it well.